The first question that we'll go over, 65-year-old female with severe knee arthritis, significant flexion contracture and valgus deformity, in the recovery room following surgery on the neuro checks, and you should always do that right after surgery, she's unable to dorsiflex her ankle. So the question is, what's the appropriate management? And there are 5 answers that are presented. You can read through those, and you know, of these different choices, the clear and most appropriate answer is to unwrap any compressive dressing and flex the knee. And the majority of people responding to this got this right. We've had cases where the nerve was out, the knee was flexed up, nerve function came back promptly. The next morning, the knee was extended, the nerve went out again, the knee was flexed up, the nerve came back, and then with gradual extension, you know, the nerve continued to work with full knee range of motion. But it shows you how sensitive the nerve can be sometimes. The anatomy of the common peroneal nerve runs along the lateral head of the gastroc at the level of the joint line. The distance from the posterior corner to of the tibia to the peroneal nerve on nice MRI study that Henry Clark did is right around 9 millimeters to 15 millimeters at this level. If you should have a nerve palsy, one of the things that can be done to evaluate this is an EMG at 3 months. Any earlier, and you may not have significant changes in nerve conduction, fibrillation potentials. It takes a while for those to develop and reliably allow diagnosis of the level of injury and be able to see whether there's evidence of returning function. So it's not really valuable early on, but by about 3 months it becomes an appropriate thing to think of doing. Treatment we have already mentioned for the acute onset of this. If the nerve palsy persists, then an AFO is prescribed, and then the question becomes whether to decompress the nerve. This is done very infrequently. It's most helpful if there's a concern that there's some actual physical constriction or direct injury to the nerve, but it can be considered after about 3 months, and probably is not of much value after about a year or so when changes in the nerve become irreversible. But it can be that you'll see improvement in nerve function for many months and up to a year in some patients. So our next question also relates to nerve palsy. It's a 62-year-old female, primary total knee arthroplasty, combined spinal and epidural anesthetic. 5 hours post-operatively, you get a call from the nurses. She's in severe pain, unresponsive to narcotic medications. There was a tourniquet used during the procedure, and on examination, the patient's not only unable to dorsiflex or plantar flex the foot, but the pulses appear asymmetric, right versus left. This should immediately prompt concern about a vascular injury. You look through the available answers, and you're drawn to the bottom of the line there, operative room, the OR for angiography, if that's the most expeditious way to get it at your hospital, and it usually is, with vascular surgery help, and if there is an injury, bypass, and quite likely 4-compartment fasciotomy. That is the answer that was chosen by 100% of the respondents. So be on the lookout for this. The vascular injury questions tend to turn up on these exams fairly commonly because the outcome can be catastrophic if people get it wrong. The next question relates to a 56-year-old male who has an uncomplicated revision THA. Post-op, he has a foot drop, and this persists despite conservative management with bracing and physical therapy. The story here is that a neurolysis was performed at 2 months, but there's been no improvement in function, and now it's 18 months after surgery. There's passive range of motion of the ankle that's been maintained with some dorsiflexion. That's important. Keep stretching and not let them get an equinus deformity. But there's complete absence of active function. And so the question is, what is the most appropriate treatment? Obviously, one option is to continue with the AFO, And there are patients who wear an AFO permanently after problems of this sort. But it's at this time interval when tendon transfer is worth considering, particularly in higher demand patients, younger patients such as this, trying to restore dorsiflexion, free them of their brace, and posterior tibial tendon transfer is the most appropriate choice and was chosen by the majority of the respondents.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.